feels just like my wife and I just moved here. We have two homes, and we have a home here in Costa del Sol. I see some of my neighbors, and we love it here.
Yeah.
And so we also, can the people in the back hear me? Do I need to speak louder? Because we have no sound system in this room. So my wife and I have been married for 33 years. We have a 28-year-old daughter who was a 2018 graduate of the University of Alabama. So everyone here is having to put up here and roll tide now. So I just want to introduce a few of the hospital board members that are here with us this evening. See Paul Velasquez and Betty Velasquez, and any other board members. Dale Leedy is our board chairman. Dale is here in the back of the room. Any other board members? Then some of my senior leadership team. We have Heidi Gerhardt, our chief nursing officer. Heidi's been a nurse here for 21 years, CNO for 5, probably feels like 21. And so chief nursing officer. Heidi's an ICU nurse, trained elsewhere and came back here and been here a long time. Travis Bender is also in the back. Travis is our Director of Quality, Risk, Patient Experience, Patient Safety, and too long for his name tag. And let's see, you got Karen Martinez, my executive assistant and right-hand person, and Janice Leha, our marketing director, compliance officer, and patient relations. And then I see Candace Adler, our rehabilitation PT, OT, speech director. Daryl Baumgartner in the back, he's our missions lead. Randy Freed is on our ethics committee, former state trooper. And did I miss anybody? Hi, Kelsey Herman, hiding back there. Kelsey's our HR director, and Kelsey, you've been in that role
almost 10 years.
10 years. So we have a very, very accomplished leadership team here, very experienced, very well trained, and I'm proud of that group of all departments. And I see Dr. Brady is our emergency department, trauma center medical director, and he's in the back of the room as well. Dr. Brady's been here about 10 years or longer. So I just wanted to introduce a few folks to you all, and I thank you all for taking time out of your evening to be here to hear about some of the challenges that your local Soul Community Hospital, regional medical centers been facing, and some of the positive things that go on here every day. And I'm going to do like a question answer multiple choice type presentation. There won't be any prizes, but there are refreshments in the back of the room. Feel free to get up and get something to drink. I see Dee Babb just joined us. She's our revenue integrity supervisor. She makes sure that our billing processes are always right and compliant. We have a lot of challenges facing our medical center, but we have a lot of good things going on here. And I just wanted to start off with, also if you have questions, we're not taking any questions from the floor. There won't be any lengthy speeches being given from the floor. There were forms handed out at the beginning of when you came in, and you need to turn those in the back, and we'll collect those forms. If you have a question you'd like to ask, we will do our best to answer it. Me or part of our leadership team that may be able to help me answer the question. But we aren't taking any questions. We're not taking any statements from the floor. And I ask that everyone please respect how we're trying to conduct this town hall. Diane McElroy, our OB director, and Nikki Turner, our gift shop manager, just noticed you all were here. So you gotta raise your hands. You can't see through the crowd. So I guess we'll start off with any other logistics, Janice.
Can everybody in the back see the screens, or do I need to dim the lights?
Maybe dim the front spots, the sliders for the front ones, because they kind of wash it out. Thank you. So what is the Medicaid agency HCPF percentage of AVRMC's payer mix and volume? The choices are A, 10% of our total volume, 25%, 30%, or 40%.
40%.
All right, y'all pretty good? You got it? Been listening to me. We've been saying this monthly at the BLTs with the chamber for 3 years. So that's great. How much of the cost of care does Colorado Medicaid, the agency, reimburse AVRMC for services rendered? 110% of our cost, 100% of our cost, 75% of our cost, 50% of our cost, or 45% of our cost? E, correct, 45%.
I'm cheap.
So Colorado Medicaid, this is an example. For every $100 AVRMC spends taking care of patients, we only get reimbursed $45. How can any business successfully operate in this environment?
Thank you.
Especially when it's 40% of your total volume.
Yeah.
So our AVRMC OB unit, who knows when that OB unit was opened? Way back, long time ago. 1927. Many of our staff were born here, many of their parents were born here, and grandparents were born here. Our OB unit has enjoyed a very, very strong and stellar reputation and been here a long time and been a pillar of the community. So how much of the AVRMC OB unit is Colorado Medicaid? 20%, 30%, 40%, or 70%?
70%.
I think y'all are figuring out where I put the right answer. So 70%. OB monthly operating loss is $50,000 a month, $100,000 a month, or $200,000 a month? 200. Times 12, what is that? $2,400,000 a year we lose on that OB unit. Mainly because it's significantly underfunded by Colorado Medicaid. Who knows how the Colorado Medicaid fee schedule is set? Who makes those decisions? Our elected state senators and our elected state representatives. The executive director of HCPF, the agency that runs Medicaid, and I'm not bashing any of the patients that are on Medicaid. That's not my intent. This is not their fault. Not at all, and it is not their fault. The state legislature gets a budget from the executive director of HCPF, and she never submits a budget that actually covers the cost of healthcare in the state of Colorado. And they pretty much just rubber stamp it and send it on to the governor for approval. She needs to be submitting a budget that covers the cost, 110% of the cost of care, so we have a little bit left over to reinvest in the hospital buildings, technology, and in our staff. But that's not how it's currently done, but that's got to change. And it's going to be a big number, but they're going to have to figure it out. And they got to learn to fund first things first. They got to fund public safety, public health, and things that matter first at 110%, and then they can fund whatever else is left over. So everyone's doing great with the answers. So Medicare Advantage, health plans, adverse impact on AVRMC. Medicare Advantage plans overall are not bad. They are great for patients that don't have the financial wherewithal for a Medicare supplement and a original Medicare. The monthly premium for a Medicare Advantage plan is approximately $150 a month. Medicare supplements are $400 to $600 a month. There are a lot of seniors in our community that are on fixed incomes, or they choose to go the route of better benefits and lower monthly premiums. And some of the plans even offer a debit card to pay that $150 premium. And so those are, Laura, thank you for being here. The Medicare Advantage plans hurt this hospital in a couple ways. So how much annually did AVRMC add to its bottom line after it converted to critical access hospital status in 2017? $100,000, $500,000, $1 million, or $2 million? $2 million. So Medicare Advantage is now 70% of all Otero County eligible Medicare beneficiaries. Since Medicare Advantage plan members can't be counted on our annual critical access hospital report, How much has AVRMC lost in critical access funding? $2 million. I had Senator Hickenlooper here back in March of last year, had all the rural hospital CEOs here, some county commissioners came, Mayor Ayala was here, many leaders in our region were here. And they came and then Hickenlooper came with his staff, and he listened, and he was shocked. He didn't even know that we couldn't count Medicare Advantage members on our critical access hospital report. And that's a travesty, and I've been working with him and Senator Bennett and other elected officials at the federal level to get that rule changed, but things move slow, unfortunately. And I need more voices. I need more loud voices, especially for people that support this medical center and want to see its services continue in a robust way. So just a little bit about AVRMC. AVRMC is a level 4 emergency trauma department. We do 1,100 visits per month, or 40 to 50 visits per day, or 13,200 visits per year. My colleagues at other rural hospitals in critical access status all across the Eastern Plains tell me that they do between 8 and 12 visits a day. So we're very, very busy, especially compared to other regional critical access hospitals. We have an imaging, radiology, x-ray department. We have a 1.5 Tesla magnet inside the building, not in a trailer. We have a brand new nuclear medicine camera, and our imaging equipment is state-of-the-art, and our techs are phenomenal. And those departments are 24/7. The lab is 24/7. We have one of the biggest chemistry analyzers of all the hospitals in this region. We don't send very many tests out. We have a 10-bed medical surgical unit. Our average daily census, meaning how many patients are laying in the bed, is approximately 5. The last few weeks, Heidi, how many inpatients did we spike up to? 14?
12 patients who were operating.
Okay, so 14. We didn't add a lot of extra staff, because we don't have a lot of extra staff. We all just rallied together as a team and made it happen. We have a 4-bed ICU. The only other hospital that I'm aware of that has an ICU may be in Brush, Colorado, that's in a critical access status. We have a cardiopulmonary department. Those are respiratory therapists, pulmonary function testing. We have a 2-bed sleep lab, and they do our EKGs. We also have a rehabilitation services department, PT, OT, and speech. We currently don't have a speech therapist because they're hard to find and hard to recruit. And I think we've been without one for 2 years, Candace? At least 2 years and going. So we do have some employed physicians, and I can see I left the word out, advanced practice nurses. So we have 4 primary care nurse practitioners. 2 are certified, 1 at acute care level, which means that she can handle internal medicine type patient cases. A geriatric certified nurse practitioner, so Jessica Haydes is acute care, Valerie Carnes is geriatric. Danae Galletti is new to us, and she's growing, and she's learning about OB and how to take care of patients prenatally and postpartum. And then we have Emily Garcia, who's at our Rocky Ford Clinic. We have 3 general surgeons, 1 full-time, 2 part-time. 1 full-time is Dr. Jackson, Thomas Jackson, and he's been here about 15 years. We have an orthopedic surgeon who's full-time, that's Dr. Mike Morley. We have a full-time gastroenterologist, Dr. Joel Corrali, and then we have a very robust specialty clinic, all specialties except for endocrinology and rheumatology, and I'm working on getting those 2 added through telehealth only, not an in-person visit. But it would be great to get telehealth, endocrinology, and rheumatology here. Dr. Singleton is a rheumatologist, but he's not been seeing new patients for years, and he's only seeing his infusion patients. So I really don't count us as having a full-fledged rheumatologist here. Just a little bit about myself. I've been a hospital administrator for 39 years. This has been one of the most challenging CEO jobs I've ever had, in keeping this hospital afloat and keeping it open, ensuring the quality of care is at the highest standards 24/7. And we're doing that. Got a phenomenal leadership team, because I don't do it alone. There's no way I could. So I have a master's degree from Trinity University in San Antonio, Texas, and a bachelor's degree from the University of Mary Washington in Fredericksburg, Virginia, in business and accounting. And I forgot to say those things in the introduction. So our financial history, our fiscal year is a little odd. It runs April 1 through March 31st. So our fiscal year operating loss in fiscal year 24, which ended on March 31st, 2024, was $3.8 million. And that's a lot of money. Our fiscal year 25, which ends this month, on the 31st, is currently at $2.1 million. So we've made a little bit of an improvement, and so that's a good sign. Some positives: we've brought back ophthalmology with Colorado Eye Institute, and I've talked to a few folks in the community that had their cataracts removed and lens implanted here. We have general surgery 24/7 with the addition of the 2 part-time general surgeons. Our ER has been covered 24/7 for the most part. There are a few gaps here and there, but that's helped. We've been able to stabilize primary care providers with 4 nurse practitioners who used to be nurses at this hospital for many years, and then went back to school, got their nurse practitioner credential, and they have roots deep, multi-generations back in this community, and hopefully none of them want to leave. They all seem happy, and we're trying to keep them happy. And we are going to be converting all of our primary care clinics to a status called Rural Health Clinic, and it's in process. We estimate that we'll complete that conversion in November 2025. When a hospital chooses to convert to critical access hospital status, it's extremely important you become a really good player at the game with the cost report that we submit to Medicare every year. It's important that we learn how to maximize that cost report submission and make sure we're getting credit for every allowable cost that Medicare allows. And we are getting better at playing that game, and we need to get even better than we have been. So we are looking at converting the clinics to rural health clinic status. Will raise the per visit reimbursement by about $30 to $50 per visit. And then it'll also help on our cost report. The more space that you have can have dedicated to clinical use in a hospital building that's a critical access hospital, the more you get in your annual settlement. So that's what we're working towards, having as much square footage classified in a clinical use, so we can get more money out of that Critical Access Hospital Act of 1997. We started a 501c3 nonprofit foundation for the hospital, so Arkansas Valley Health Foundation. We also hired a grant writer. Erica Retzlaff has been with us, I believe, a year in April. Erica has 5 years experience working in community development and community fundraising, grant writing, and then she was with the Medicaid Regional Accountability Entity for a couple years that covered this area, and she's doing a great job as the executive director of our foundation. And I held out for about a year filling that position, waiting for that right resume to come through, because I knew what I was looking for. So that's going to start, that takes time though. That takes years to start generating the revenue. But we've been able to get some pretty sizable grants already, and even some smaller ones. And then the health fair is coming back. We're going to do it on our own. I don't know how many of you all realize we partnered with an organization called Health 365 or 9 News. Well, they went bankrupt, and all those labs that they supported at health fairs across the state stopped happening. So Janice has been working with our lab manager and lab corps, and we're going to partner with them, and we're going to bring that health fair back where we'll have booths with all the different agencies that support healthcare in this region, and bring that health fair back in the fall of 2025. So we're excited that we're going to be able to do that. Last time we had a health fair was April of 2023. So I just wanted to thank everybody for coming out and hearing what I had to say. Do we have any questions that anybody's submitted? I'm going to go back to the beginning. Thanks, Janice. So the first question is a good question. Have we looked at joining a large hospital organization? And I'll just fill in a little bit, like UC Health, like Common Spirit. We have a very strong partnership with UC Health. Their rural liaison person was at the meeting I was at Parkview. We have a very strong relationship. I sat at the right hand of Lonnie Kramer, who is the president CEO of UC Health for Southern Colorado. And one thing that I've been spending a lot of my time on is legislative advocacy work, but also partnering with other hospitals and actually building relationships outside La Junta. I don't come to the hospital, sit in my office all day, and then go home. I have to spend a lot of my time in public-facing roles, and I do enjoy doing that part of it. So I've built these relationships that are coming home to be a positive thing for this hospital, because I have people I can reach out to. At that meeting today, all the rural federally qualified health centers were there. Valleywide was there, represented by J.C. Carica. Peak Vista was there. Public Community Center Health Center was there, and Salute was there. And I think that was it. That's all the FQHCs. Southern Colorado. I didn't realize all the FQHCs in Southern Colorado are all losing significant amounts of money as well. That was an eye-opener for me. I did not know that. That's not good. They haven't had a rate increase in 10 years. Is that right?
I don't know.
That Casey said
Yeah.
that. So we want to remain independent. And I may want to ask Dale Leedy, our board chairman, if you want to address part of this question, or want me to just continue?
If you'd like, I would.
So, we would join an affiliation with a larger health system if it really benefited La Junta and Otero County, Bent County, Los Animas, and all the counties out here. I don't want to affiliate with a health system that's just going to strip all the services out and then say everybody can drive to Pueblo to Parkview. That ain't going to work.
I think it might be worth explaining the relationship from the Mennonite board to the
Thank you.
city. I think that's an important aspect.
Good, thank you. Thanks, Dale. So back in 1998, I don't know how many of y'all know this history, the Mennonite Hospital and the City Hospital merged and formed Arkansas Valley Regional Medical Center, a 501c3 independent, not-for-profit, designed to keep healthcare services local. And there was some funding in that as well. And there is some governance relationship with the city of La Junta. So we do have a board seat that must be a sitting city council member, and that's Paul Velasquez. And then we have regions for board seats as well. So we have representation from Bent County, that's Dale Leedy in Los Animas. We have Crowley County, that's Gary Gibson, who's the county coroner and EMS. Then we have Rocky Ford, that's Rob Pickering and Joe Petlicki. Then we have La Junta seats, and I'm not going to get into all the names, but that consolidation agreement is what it's called. That's the title on the top of it, and it helps us have the support of the city, not financial support, but just working together as teammates to help keep this hospital services going and keeping them robust. Is that a good enough answer? So I've been talking with UC Health and the other big systems, but I have rules of engagement. I said I'll be glad to talk further with you about affiliation, but I want to see you invest in the community and not take services out. And UC Health hasn't gotten back to me in any substantial way for about 9 months. So, and they're busy merging in Parkview. I'm not really bashing them. And they're also merging in Estes Park into UC Health. They got their hands full. I learned today that Parkview is still losing $11 million annually. I don't know how many of y'all have been to Parkview. I went there for the first time today. That is a beautiful facility. We're fortunate to have it in our region. So, Douglas, did that answer your question?
Yeah, it just seems like, I'm sure you have done that.
Yeah, but I do have rules of engagement of what we'll agree to. if we do need to affiliate. Let's see. What are your plans if someone comes in late labor with no prenatal care or placenta previa? You want to take that one, Heidi? That is getting way too clinical for me.
One thing that I think has been really important through this entire process is.
Can you speak a little louder?
One thing that's really been important through this process is we've had a lot of support from UC Health, Pueblo Community Health Centers, and Peak Vista. I think sometimes in hard times you actually find the resources that you didn't know were there. UC Health has been really great. We're working, we have calls with them. Dr. Brady has been involved, Dr. Regular has also been involved, and Children's of Colorado has also been involved in that. And if a patient did come to our emergency room, we are required by EMTALA to treat and stabilize that patient. So if that patient should present and have to deliver, we would do all that we possibly can. It's not going to look the same for that patient as if they were up in the OB department. That's the reality. But we would involve UC Health. Hopefully they could get their team here as well as Children's. If the patient was stable enough, our goal would be to get them transported out. That answer the question?
Natalie, did that answer your question? Okay.
Follow-on question is, what are people in the community supposed to do with no transportation when they go into labor and aren't able to get themselves to Pueblo or Lamar? Do you have a suggestion for them? I would suggest they present here so we can assess them, stabilize them in our emergency department, and transport them as quickly as possible. That'd be the safest decision to make. Don't just do something on your own or make it up as you go. Why was this hidden from the city council? This is a community hospital. This was not hidden from the city council. I've been reporting on this through the chamber BLTs, which city council members attend every month for the last 3 years. So this has not been hidden from the city council. I've been to some city council meetings, but I felt that enough of them were attending the BLTs that it would be redundant to just stand in front of a convened city council meeting and repeat what I just said the previous Thursday. So this was not hidden. Anyone that thinks that is wrong. All right. Next question comes from Janet. It seems our medical center is seeing a transition from families to an aging population. Are you looking at doing something about this trend? Well, I can't stop people from aging. Wish I could. I'm aging.
Figure out how to do that and it'll solve your money problem.
Yeah, it sure would. So, in all seriousness though, we do have, Valerie Carnes is certified in geriatrics. So we do have a specialized nurse practitioner that is certified for geriatrics. All of our nurse practitioners take care of geriatric patients. We do have private practice. We have Valleywide, who has a primary care physician and nurse practitioners in their clinics throughout the valley. They also have behavioral health, which is very robust and very good. And we're very fortunate to have all the behavioral health services that we do have here in La Junta through formerly Southeast Health Group, now part of Valleywide.
Along with other independent.
And then, thank you, Travis. We also have private practice. We have Summit. They have 2 to 3 nurse practitioners. We have Aglands Health that has 2 nurse practitioners. We have Radiant Health and Rocky Ford, 3 nurse practitioners. I'm probably leaving Ryan Medical. There's who? Jenna White, the chiropractor's office. So there is other primary care. Unfortunately, we will not have any family medicine physicians after the family medicine OB physicians leave after April 30th, because they do both, and they really primarily do OB, and that's what they all want to do as a career. And so they will all be leaving. So we'll have 1 physician at Valleywide. I don't know if y'all are going to add more than 1 in that clinic. It'll be based on demand. Of how many physicians Valleywide adds. We are working with Springfield's hospital about a part-time family medicine physician that will split between the 2. So they have a new CEO. He's already been up here to visit and tour our hospital. Nothing concrete on that recruitment. He interviews down there on March 14th. And he's very experienced and well-seasoned family medicine physician. And the CEO, Rex Walk is his name, down at Springfield, has worked with this physician before in Phillipsburg, Kansas. Is that right? And so those are some of the things we're working on. So, Janet, did that answer your question? Yes. This one does not have a name on the top of it, so we won't have any way of getting back to you unless you want to tell me who wrote this one. What is the name of the committee and those who are on it that are working on grant funding? So when we formed the foundation, it was odd to me that this hospital never had a foundation before. Every hospital I've worked at in my 39 years has had a foundation, a mechanism to raise money, have tax credits, all those kinds of things. And so we set a foundation up, a 501c3 foundation under Erica Retzlaff's leadership. It's a separate board, it is a separate tax ID from the hospital, but the sole beneficiary in the bylaws of that foundation is the hospital. We have raised a little over $130,000 so far, and it's only been in existence about 6 months. We've done a direct solicitation to the community via postcard, and we got some donations out of that solicitation. So the committee that's kind of overseeing the foundation is really the board of the foundation, and it's got a startup board, which includes myself and Erica, Dale Leedy, Betty Velasquez is the board chairman, and then Rob Pickering is on that board. The hospital board members agreed to sit in the board seats on the foundation temporarily until we grew that board to a point where it was big enough and had enough community representation that they didn't need to sit on the hospital board and the foundation board, and it helped accelerate the opening up of that foundation. Anything you want to add? Okay. All right. So the way the grant process works is there's a form that any department head can fill out, and they can request funding from the foundation by submitting a structured form, and then that gets approved by the board. It will first go to our senior leadership team for vetting and questions, and then it'll go to the board and for their approval. We're still in the early stages with the foundation raising funds, so we haven't funded anything yet. Well, that's not true. We got a directed donation from a generous benefactor in the community that was so impressed with their care in our emergency trauma center, they wrote us a check for, I think it was $1,000. And they wanted that money to go directly back into the emergency room trauma center, and so that's what's happening. We're buying some equipment and supplies to help better equip that department with those funds. So that did run through the foundation. I think I answered that question. How do you plan to keep retained staff up to date on skills to be able to support emergency C-sections or preterm pre-up deliveries? We are not going to be doing any emergency C-sections here. Somehow that information got communicated in the paper incorrectly. We are not doing C-sections at this hospital after April 1st. That is dangerous and unsafe. I don't think the EMS crews want to do that either. No. So we will bring the patients in our ER, we will stabilize them, and we will transfer them as fast as we can. I don't know how many of y'all realize the helicopter is based here in La Junta. So we have that benefit. They can get the crew over here, get the crew from the NICU unit out from Colorado Springs, and we are going to activate that process as early as we possibly can. We've even created a new code called Code Stork, and that will activate all hands on deck, come to the ER, and help deal with the situation they're dealing with the expectant mother. So, answered that question. I think that's it. Submit the questions. My big ask of everyone here and everyone that's on the streaming devices is the only people that can affect changing how this hospital and all rural hospitals in Colorado are funded at 110% of cost. That's what it needs to be, 110% of cost, not 45% of cost. 110% of cost, so we have a little bit of money left over to reinvest in our facilities, our equipment, and our staff. You need to contact the people that cast the votes. The governor's not the person to call or write to. He doesn't cast a vote. It's the state senators, state representatives for things that are state, Medicaid. They're the ones who decide how much they're going to fund or not fund Medicaid. The executive director of HICPUF needs to submit a budget that makes sense and covers 110% of costs, not 45%. But they don't know that. I'm not going to say they rubber stamp her budget, but they kind of do. And they need to stop doing that. They need to tell her to submit a real budget. What is it really going to cost to take care of Medicaid beneficiaries in the state of Colorado? So there's a handout at the back with Janice. It's got all the contact information. In the state of Colorado, the committee that has the most power, more power than even the governor, is the Joint Budget Committee. Those are representatives and senators, Republican and Democrat, that are appointed by their colleagues, and they decide how the budget is crafted. Colorado does a zero budget process every year. You wouldn't know it with the way the Medicaid budget's been funded. And that budget needs to focus on first things first. It needs to pay hospitals and doctors 110% of the cost of care. And then everything else that's in that budget, MedRide and all these other extras, if they have money left over, then they can fund those things too. And we got to start doing our state budget that way. We got to set some priorities on what is important and what's not. What's really important and what's not. So we'll that handout of the Joint Budget Committee, as well as our U.S. senators, our U.S. congressmen, and our 2 U.S. senators. Writing to Ty Winter and Rod Pelton will, help a little bit, but they're Republicans and they're outnumbered big time in the legislature. You really got to go to the Joint Budget Committee where you've got Democrats and Republicans who all actually do try to hash this out and come up with a good budget. So again, my ask is take those handouts with contact information and make our voices louder. My voice can only be so loud. I'm one person. And I've been screaming from the rooftops in Denver and from meetings here about what the issues are and what the solutions are, and we need to start getting our elected officials held accountable and do their jobs. So that's all I have to say. Thank you everyone for being here. Grab some refreshments on the way out. Dale, were there any remarks that you wanted to make?
Just this board is committed to keeping a hospital that's viable in this community. We're in unison on that, and you just need to know that that is our commitment to this region. We're going to do all we can to keep it viable and conserving.
Absolutely. There are no plans to close any other services other than OB. So, and also, if you hear rumors, go check our website first before you start passing gossip around town. Because the truth is posted out there most of the time, or come talk to me. I'll give you a straight answer. You may not always like it, but I will give you a straight answer. So thank you again. We're adjourned.
With your Southeast Colorado news from Arkansas Valley Regional Medical Center, I'm Adrian Hart.